Okay, and we are live. Good afternoon, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Beti, who will be teaching us about anesthesiology. As always, please remember the Google form for attendance will be posted in the chat box and in the description of this video at the end of the session. With that being said, Dr. Beti, you can get started whenever you're ready.
Awesome. Hi, everyone. Thank you so much for just being present on this live session. I am Dr. Beti, and today I'm going to be talking about anesthesiology and kind of talking about, what I do every day, what kind of cases we see, and so on. So I have a lot of slides, so I'm going to kind of go through them pretty quickly. The material is for, anyone interested in anesthesiology, so pre-meds, anyone interested in anesthesiology who are medical school, so medical students, and then early residents. So if some of the material is a bit heavy, just comment saying this is too complicated or whatnot, and I'll just move on. So my objectives are the following. So first, I'll introduce anesthesia and the specialties in anesthesia. And then we're going to discuss basic anesthesia consideration for specific cases. And then I'm going to expand on some core anesthesia topics as it relates to patient care. And then lastly, I'll talk about diversity, global health, and equity in anesthesia. This is a topic I'm very passionate about. And I feel like in medicine, we don't really have formal training in this. So this is maybe a small opportunity to get exposed to a very small part of what global health and equity is. Okay, so another reintroduction. So I am a general anesthesiologist. I work here in Northern California. I am Ethiopian by origin. I was born and raised in Ethiopia, and I did a lot of my schooling in this country. I came here when I was a teenager. I did 3 years of undergrad at UCLA, and I majored in French. And initially when I was in undergrad, majoring in non-science was kind of like a big no-no. It was where people were just starting to think about not majoring in science. So I was definitely one of the early on non-science majors, and it worked out just fine. And so if you're interested in going to medical school, you can really major in anything you want, pretty much. And then after that, I took a gap year. I wasn't sure if I should be applying to medical school right away, if I should take a year off. So I just took a year off tutoring students, and I took some community college courses. So, because of my French major, I didn't take a lot of the upper division classes. So I ended up taking physiology, pharmacology, physiology, microbiology, and anatomy. So just to get some exposure, did well in them anyway. So that was a really good move from my part. And then later on decided to kind of, do a little bit more of a digging into science and strengthen my background in that. So I did a master's in pharmacology and toxicology. And I would say that's probably the first time I felt like I really got a good look into what medicine can be like. I loved pharmacology. I loved physiology. And we did a little bit of toxicology, and that was kind of my very first introduction to what anesthesia can be like. So I remember thinking in my head, I really like these things, if you're naturally drawn to physiology, if you really enjoy anatomy, if you really enjoy pharmacology and how drugs interact with your body, you can probably really enjoy anesthesia as well. So I remember just thinking that in the back of my head. When I went to medical school, I did my anesthesiology rotations early on, thankfully, and immediately I knew that this was going to be something I'm really interested in. So I think having that pharmacology background definitely helped, and having that interest in physiology helped as well. And then after medical school, I did internal medicine for a year for my intern year. Usually for anesthesia, depending on what program you go into, the first year is a year of either transitional year where you do different kind of specialties, or you can pick, internal medicine or surgery. And then your anesthesia core training is about 3 years. And I did that at UC Davis. And then after I finished residency, I decided to do this really interesting fellowship in global health and equity in anesthesia, where I got to work on equity projects around the world, which is really nice, and also locally. So that's kind of my background. And I've been working now in private practice for about 6 months. So anesthesiology is very vast, and it's a very wide field. People think of anesthesia just, put patients to sleep and that's it. And it's really not. That's not the only thing that we do. And so there's general anesthesiology, there's pediatrics, where you take care of kids. Regional anesthesiology, where you mostly do nerve blocks. So, patients who get surgery and need to have pain relief afterwards, you do blocks for them, and we'll go over that a little bit later. You can do obstetrics anesthesiology, where you mainly take care of obstetrics patients during their laboring phase or afterwards or before. So you can, you do spinals and epidurals for C-sections and things like that. Critical care, where you're in the ICU and you're the ICU doc. And so you take care of really sick patients. And then there's cardiothoracic anesthesia, where you basically do anesthesia for patients who get heart procedures, heart surgery, thoracic surgery, and things like that. And then there's all these other subspecialties as well that are not ACGME approved that you can still train on and get additional training. So, and they're up here. I'm not going to go through them, but it just kind of shows you how wide anesthesia can be. So I have this just to kind of give you an idea of what my day is like. For those who are wondering, like, do people work all the time? What's the usual kind of schedule? So I usually wake up around 6:15, 6:30, and then I try to get to the hospital by 7:20. So I arrive. I have about 10 minutes to set up my room. So depending on what I do, sometimes if I have to do my own cases and I'm the primary anesthesiologist, then I have to set up the room, meet the patient and things like that. So if I'm doing my own cases, I go in, it takes me about 10 minutes to set up the room, draw my drugs, and then review the patient's chart really quickly. And then between 7:30 and 7:40 is when we go see the patient. So we go interview the patient. And then between 7:45 to 7:55, you can go back to your room, reset up, talk to the surgeon. By 8 a.m., you're in the OR, okay? If I'm not doing my own cases, if I'm supervising CRNA, so we work with a lot of nurse anesthetists. And so if my job for that day is to supervise CRNAs, I usually have 3 rooms. And so I don't have to set up my own room. So I, look up my patients to make sure everything's the same and nothing has really changed. I touch base with my CRNAs and have a plan. We agree on a plan for anesthesia and we discuss that with them. And that's kind of like how my morning kind of goes. And then in terms of responsibility on here, I've already kind of told you guys, I can either do my own cases or supervise rooms. This happens, the ratios, varies as 50%. So 50% of the time I do my own cases, 50% of the time I supervise a nurse anesthetist. This is kind of the setup of a, private practice. If you go into academics, it can be different. Some private practices only have MDs, so you only do your own cases and so on. So it really depends where you end up after training. And then some days I'm the block attending. So when I'm doing blocks, it's just me. And so I go around in pre-op and PACU and I do nerve blocks. And I can talk to you guys about that in a few minutes. And so I do epidurals, I do nerve blocks for patients. And then I have patients on the floor as well that I go see and round on. And those days can vary. It can be a very light day, it can be a very busy day, depending what's going on. And then some days I'm doing obstetrics anesthesia. So, I do elective C-sections, I place epidurals and so on. I do spinals. So that can be also an easy day or a very busy day, depending what's going on. So that's kind of the gist of what, my days can look like. Some days, most days I go in by 7:30 and then I'm out of the hospital by 4 p.m. sometimes 5 p.m., sometimes 6 p.m., sometimes 7 or 8 p.m. It really depends on what shift I'm working and how things are going, okay? I would say if my shift that day is a 4 p.m. shift, me getting out at 4 p.m. is very high. So usually you will get out on time if depending on what your shift is, what shift you're on. In terms of call, we do take a lot of calls. So I take a call, I would say once every 10 days or so. Once a week to once every 10 days. And this is either home call or in hospital call. So in anesthesia, you're almost always guaranteed to have call unless you're working in a practice that doesn't have a lot of call or if it's an outpatient practice. So that's that. So now let's talk about anesthesia. So anesthesia, what are the goals of anesthesia, right? So these are the 4 A's, kind of the basics of anesthesia. One is amnesia. So you don't want to have any memory of the event. You don't want to remember anything. So lack of awareness, you want to be completely unconscious and you want to have analgesia. So you don't want to be moving at all and not feeling any pain. So your somatic and autonomic reflexes are completely gone. And then akinesia is lack of movement. Obviously, you don't want to be moving under anesthesia, under surgery. And there are 4 stages of anesthesia. Okay, stage 1 is when you have some analgesia without amnesia. So this is kind of light, moderate sedation. Stage 2 is when you're going into surgical anesthesia, that phase between kind of being awake and not and kind of being completely asleep. That middle stage, or stage 2, is called the excitement phase. And it's a very dangerous phase because that's when patients don't know where they are, they don't know what's happening, they can be very combative, they can be very dangerous, and their breathing can be very erratic as well. So this is a very important stage for us to know and identify so that we can take care of patients and make sure they're safe. And then stage 3 is surgical anesthesia, you're unconscious, your vitals are normal, this is kind of where you want to be. And then stage 4 is like too much or too deep of an anesthesia that can lead to coma or death. So there are different things. We talked about the stages of anesthesia. There are different points of anesthesia and how they happens, right? So initially, what you do is, when a patient comes in, in the OR, you want to, they need to go off to sleep. You give them what we call induction. So you do an induction. So you're inducing anesthesia in a way. And so again, we talked about the 4 things about the 4 A's in anesthesia. We want to make sure they're amnestic. They don't remember anything. So we give them an anxiolytic drug like midazolam or Versed. And that kind of, they forget what's going to be happening after that dose is given to them. You want to make sure they're completely unaware. So we give them a sedative drug, usually it's propofol. You give them some drug for pain or an analgesic, usually it's an opiate that we give, but you can give other things as well. And then you want to make sure they don't move. So we give them a paralytic. Obviously, I have a lot of questions for people asking, am I going to be paralyzed under anesthesia? That's definitely not something you want to achieve as an anesthesiologist. You don't want your patients to be paralyzed and aware. That's probably everyone's nightmare. And so we make sure a patient is completely sedated and asleep and unconscious, and then we paralyze them. Because sometimes if you don't paralyze them, you can still have a little bit of reflexes and your legs can move, you can start coughing and things like that, which can interfere with surgery without you being unconscious. And so once you induce, then you maintain the anesthesia. Right? You want to make sure they're going off to sleep, and then now you want to make sure they stay asleep. So you need to give them something for them to stay asleep. Otherwise, the drugs get metabolized from your body, right? It gets metabolized from your liver, your kidneys, and other parts of your body, and then the patient wakes up. So you don't want the patient to wake up. So you have to maintain them on something. And usually, you can maintain them using 2 different techniques. The first one is inhaled anesthetics. So you give them a volatile agent, like a gas, that they breathe in. That's why they have either a tube or some sort of airway that goes into their lungs, and you can ventilate them. So the gas goes into their lungs, and then it gives them the necessary anesthesia to keep them asleep. Okay. If you're not doing that, right, if you're not giving them an inhaled anesthetic, then you have to give them something else. And usually you do an infusion of an anesthetic drug. So it can be propofol, dexmedetomidine, some kind of drug that would keep them asleep. Ketamine is another drug as well, okay? And then emergence is when you're coming out of anesthesia. So if you think of it as a plane landing, so you're taking off, you're staying on the, in the clouds, and then you're finally landing. That's literally how anesthesia works. You're taking off, that's induction. You're maintaining that altitude, that's your maintenance, and then you're going to emerge and land, right? You're going to wake up. So emergence, when planes usually depart and land, those are the 2 most most precarious spot of just a plane moving, is them taking off and landing. And same thing with anesthesia. A patient going off to sleep and then landing, waking up, those are places where things can really go wrong. And so emergence is when the patient is awake, they're following commands, they have normal respiration and tidal volumes, their vitals have to be stable, they're able to move, and they have full strength, and they're not paralyzed, and they're making some kind of purposeful action. So when you're waking up from sleep, when you wake someone up from sleep and they're half asleep, they're half asleep, right? Because they're not really responding well, they're not doing something that makes sense. They don't have any purposeful action, right? Same thing with anesthesia. Someone is waking up and they're trying to punch you, that's a purposeful action because they're trying to get away from whatever attack is coming to them. But really, you want to make sure if you pinch their finger, they're able to kind of localize and know that someone is pinching them, right? If you pinch their finger and they're not even moving, then that means they're completely anesthetized. Not that we pinch patients, we don't pinch patients. Okay. So that said, let me go into our case study. There's a question that says, what would you do if a patient enters stage 4 and has respiratory issues? So when a patient enters stage 4, you'll be able to know that's when they're very deep into when they have too much anesthetic. Our anesthesia drugs they cause hemodynamic changes to your body. And so when they're in really deep anesthesia, you start seeing that their blood pressure drops, their heart rate can start dropping as well. And these are signs that will tell you that the patient is extremely deep. So you can start lightening up their anesthesia. So you can make sure they don't get too much anesthesia. Okay, so case study. So I have one case, but I have a bunch of scenarios with that one case. So hopefully it helps you guys kind of go through the different scenarios. So it's a case I made up, by the way. This is not a real patient, and so this is not something that happened for real. So there's a 69-year-old female with a history of CAD, which is coronary artery disease, okay, hypertension, COPD, and reflux, is scheduled for a laparoscopic cholecystectomy. So this patient has some kind of heart problems, right? They have some blood pressure problem. They have some lung problem, right? With COPD, you usually get it with one of the main ways of a patient getting it is a long history of smoking, right? Having emphysema changes in your lungs, and then GERD is reflux, and so having reflux and food come up, right? This is the 4 things that the patient has, and they're scheduled to get a laparoscopic cholecystectomy. So the procedure laparoscopic, meaning that they're not going to cut the entire abdomen open. They're going to put little ports in your stomach, and then they're going to put little videos and instruments and take the gallbladder out that way, okay? Otherwise, the patient is stable, okay? Yeah. Let's see. So what additional information would you like on this patient? Fortunately, this is not a very interactive session, because will be the time where I ask you guys, what do you think? What kind of information do you know? So I will answer my own question. So when you have these 4 things, you want to assess more and inquire more about these 4 things that the patient has, right? CAD, right? Coronary artery disease. So the first thing that comes up to your mind is this patient has arteries in their heart that are not very open, right? You have basically fat plaques in your arteries. And so you want to ask, okay, what's your functional capacity? Are you able to walk? Are you able to run, right? Do you have any chest pain? Do you have any shortness of breath? Do we have an EKG on file, right? Is there a stress echo, right? Anesthesia, what you have to think of anesthesia as like a marathon in a way. You're really stressing the body, right? You're putting the body into a situation where it's going to have a huge insult, which is surgery. There's a huge insult to your body. It's like, I'm sitting here, if someone cuts my finger, right? Imagine the kind of response my body would have. And you're going to have the same response during surgery. And so we're trying to mitigate that response by giving anesthetic drugs to make sure your heart rate doesn't go super high, your blood pressure doesn't go super high, you're able to get oxygen, and we're trying to make sure your vitals stay within your normal range during surgery. And so a good way of assessing someone's heart is to put them under anesthesia, but that's not really a good plan, right? Because you don't want them to have a heart attack under anesthesia. So we try to mimic a stressful event by doing a stress cycle, right? You stress their heart with either a drug or you have them run, and then you see what happens to the heart. Is the heart able to function the same way? Is there any areas that are ischemic? And so that's something that's important for a patient who has CAD. And then depending on what the stress echo shows, they might get a cath where they inject some dye into their coronary arteries and actually look at their arteries and their coronary arteries and see if there's anything that's blocked, and then they can put stents that way. Anyhow, let me not divert. So COPD is the same thing. You want to ask them, do they have any dyspnea with exertion? Do they have any shortness of breath? Are there any kind of treatment for that? Do they smoke? Do they have any pulmonary function tests, right? These are the things that should go in your mind as you're going to this patient. High blood pressure, you want to know if the blood pressure, is it well controlled or is it not well controlled, right? You don't want to do surgery on a patient with a blood pressure of 200 over 180, right? So that is 200 over like 120, right? That's really high. Or you don't want to do surgery on a patient who's super hypotensive. GERD wise, are they symptomatic or not? So why is GERD so important, right? If a patient has reflux on a regular basis and they're sitting home and they're, hear me talking to you, if I get reflux on a regular basis, during anesthesia, we intubate them. And during intubation, the reflux can be ongoing and they can get food out of their esophagus into their lungs and get aspiration that way, right? And get a horrible infection that will send them to the ICU and cause really bad issues, right? So you want to ask all these questions. You want to ask them if they have cholecystitis, do they have nausea, vomiting, do they have abdominal pain? These are all things that we want to ask beforehand so that the patient is kept safe during surgery. So we can anticipate things and make sure we do our anesthetic a certain way to make sure no harm is happening to the patient. And then other things you want to ask is allergies. You don't want to give a drug to a patient that they're allergic to, especially if they get anaphylaxis, right? Can you imagine if you're allergic to Bactrim, well, we don't give Bactrim, but if you're allergic to Ansef, which is a common antibiotic that we give in the OR, and you didn't know that, and you gave the patient Ansef and they get a huge anaphylactic reaction and go into shock and they have to go to the ICU, intubated on multiple pressors, right? A very simple thing that can really lead to devastating consequences. We ask them about current medications. What medications are they taking? Are they taking their medications? Their weight is really important, and their BMI, because weight and BMI is associated with outcomes afterward with surgery, right? Obese patients don't heal well, right? Patients have skin infections afterwards. For anesthesia, if the obese patients can be difficult airways, difficult intubations, difficult IVs, okay? Difficult positioning as well. So this is something important to know beforehand. Do they have a prior anesthesia record? Were they intubated before? What did their intubation show before? So we usually look at intubations from, whenever they had their surgery and look at the intubation note. Do they have any labs? Are they NPO? Did they eat an hour ago or did they eat yesterday? And so knowing their NPO status, again, is important to avoid aspiration and having food or liquids or any kind of GI content go into their lungs and cause infections. You also want to know the length of the procedure, right? Is this like a 2-hour procedure or is this going to be a 10-hour procedure? That makes a huge difference in your anesthetic management, right? If you have a 10-hour procedure, you're going to need a Foley for this patient, right? Because the patient's going to be under anesthesia for 10 hours. They can't pee. You need to kind of monitor how much urine they're making so you can assess how much fluid you're going to be given. So a Foley is indicated for that patient. Versus like a 2-hour procedure where the patient just peed beforehand and pre-op, then, who probably doesn't need a Foley. And then you do a physical exam, okay? So in terms of, let me see. I'm just trying to see your questions. Okay, I'm just going to answer a few questions as I'm going. What causes certain patients to metabolize anesthesia faster than most? Really good question. It really depends what kind of drugs. Some patients can be metabolizing some drugs faster than others, depending on the type of drug. That's number one. Some patients who are on certain drugs can also metabolize drugs faster. So usually anti-epileptic drugs, patients metabolize our paralytic drugs faster. So we need to dose them a little bit higher. So it really depends. Some patients who have liver issues or kidney issues can be not metabolizing drugs faster compared to others. Which of the drugs interferes with birth control? There's a couple. One of the drugs that we use is called Sogamadex. It's a drug that we use to reverse our paralytic drug. So, we give you a paralytic drug and then afterwards we give you another drug to reverse it. That drug can interfere with oral birth control pills. And so we usually counsel patients to be on 2 different birth control methods afterwards. Does the chance of high-risk complications due to anesthesia increase as the time of the surgery increases? Very good question. So you're saying does your complication risk increases at the time of surgery increases? I wouldn't say it completely increases your risk, but sometimes if you're under anesthesia for a really long time, let's say you're under anesthesia for 10, 12, 13 hours, we start seeing hypotension and other things because of the anesthesia being there on for such a long time. And usually, if you have a tube in your mouth for such a long time, you can get swelling around your throat. And so we may not be able to extubate you. So that can be an issue afterwards. So definitely being under anesthesia, being under non-normal circumstances for a really long time can definitely cause some issues, especially anesthesia related. Yeah. Okay. And then, so going back to our patient, the patient has a stent already. Their stress echo was negative. He's able to, walk around their home, but nothing more than that. He has high blood pressure, or she has high blood pressure that's really well controlled. She has COPD as well. She's on Advair and albuterol. She takes Protonics from her GERD. She's had no surgeries on anesthesia before. She has a stent that was placed under a cath lab under sedation. She's not allergic to any medications. She's been appropriately on PO. Her labs are fine. Her hemoglobin is 10. She's a little bit anemic. Her creatinine is a little bit elevated. Her EKG has Q waves in leads 2 and 5. Usually Q waves show kind of an old heart attack or some kind of ischemia in the past. And then on physical exam, she does have wheezing bilaterally in her lower lung fields. So knowing this, what's your plan, right? Once you see this, what's your plan moving forward? So we always try to optimize patients before anesthesia. Actually, you know what? Before I go into that, let's do an airway exam. So we also do an airway exam, which is really important. This is the Malampari score. So I'm sure you've heard of this before, but we ask patients to open their mouth and then we look into their mouth. And depending on what you see, we give it a number. So class 1 is when you're able to see everything. So you can see the uvula, the soft palate, and the hard palate. This is like a great thing for anesthesia because that gives you an idea of how your intubation is going to go. Usually, if you have a grade 1 view, your intubation should be pretty straightforward. Class 2 is when you see, or grade 2 is when you see just part of the uvula. And then you still see the soft palate and the hard palate. And then 3, you see less of the uvula, but you do still see the soft palate. And grade 4 is when you only see the hard palate. Grade 4 should scare you. If you have a patient who has a grade 4 view, already in your mind, you should be thinking, this can be potentially a difficult airway. Okay, and there are pictures here at the bottom, right? So you see this guy on the very right side, and then the patient on the left side have a completely different airway. So other than that, in terms of airway exam, the Malampari score is something that you can use, obviously, but there's a lot of other things that we also assess during the airway exam. So we look at the thyromental distance. So the thyromental distance is from your here, from, I don't know how you say it, from your chin pretty much to the top of your thyroid. And usually you should be able to put at least 3 fingers, and you can see mine, you can easily put 3 fingers here, and it kind of shows you how anterior your airway can be. So my airway is lower and not like all the way up, making it a difficult intubation in the future. So having at least 3 is what we go for. I can probably put 4 for me. Some patients, you can barely put 2 fingers because their neck is shorter, they have a short neck, and then their larynx is all the way up. So that kind of tells you that the airway is very anterior. So when you go and DL and you look inside, the whole anterior, the whole larynx is going to be moved upwards. And so it's really hard to get a view sometimes. The neck mobility is a huge thing. So if you have a patient who's not able to move their neck and flex their necks, that becomes a difficult thing, right? Because you won't be able to extend the airway and open up the airway. Same thing with neck circumference. So having a thick neck as a predictor for difficult ventilation. So not being able to ventilate the patient and get oxygen and air into their lungs, and possible difficult intubation too. Incisor length. So having really long incisors can be difficult to intubate. Having no teeth. So sometimes patients who don't have any teeth have cheeks that are very sunken. So their cheeks will be like in. And so when you try to put a mask on and try to ventilate them, the air leaks out. So they can become a very difficult ventilation. Obesity, obesity goes with neck circumference and having a lot of excessive tissue. So once you're induced, once you're completely relaxed, when we give you that propofol, fentanyl, the drugs that you need for induction, everything kind of relaxes. So the fat tissue, your larynx, everything relaxes and collapses. So if you're obese and or have severe obesity, it will become very hard to get air into your lungs if you have all this tissue kind of obstructing it. And then I have on here like history of ENT cancer, any kind of cancer in your mouth, in your nose can be difficult. Intubation, history of radiation to your neck. So radiation can really cause your tissues to fibrose and make it really tight. So some patients might not be able to move their necks or open their mouth after radiation. So that can be a very difficult situation. And then having a history of difficult intubation in the past. So if a patient is a prior difficult intubation, it's good to review their chart and see why they were difficult intubation, and the likelihood of them being difficult again is high. So you should really have a high suspicion of difficulty again. So going back to optimization, so you've done all the stuff for your patient, and now you're like, okay, what can I do beforehand, before the patient goes into the OR, to optimize them? Sometimes we cancel cases because if patients are not optimized. If a patient with CAD, like this patient, comes in and tells me they still have chest pressure, we automatically cancel the surgery because that can mean they have an unstable angina, right? They have ischemia of their hearts, and it's only going to be exacerbated during surgery, and they can get a heart attack. So we try to, if we are not canceling a case, obviously you try to optimize every patient that comes through the pre-op to make sure they are fully optimized for their surgery. So if a patient is anemic, you start thinking, do they need a transfusion right now? This patient doesn't need a transfusion. They're anemic within the normal anemia range. They're not like, a hemoglobin of 5, 6 would need a transfusion, but not like a hemoglobin of 10. But they might need a type N screen. So if if they're doing surgery and the surgery doesn't go well and they need to get a blood transfusion, they might need a type N screen. So these are things that can go, that you can start thinking about. Wheezing. So if a patient is actively wheezing, you can give them a treatment beforehand. So you can give them albuterol and nebulizer, because oftentimes these patients go in and they have bronchospasm and things like that in the OR. Reflux. So if they're having active reflux, right, you can give them Vicitra, neutralize the acid in their stomach. You can give them like drugs like an H2 blocker, so things like that will make it less harmful if they were to have an aspiration event. And then we usually try to do multimodal analgesia. So multimodal means we don't want to give everyone opiates, right? Opiates only work on one receptor, right? They're mu opiate or kappa receptors. And so we really try to give them other drugs that work in different receptors, to give them a multimodal analgesia. So we have different receptors kind of tackling the same problem, which is pain. So we can give them Tylenol beforehand. You can give them gabapentin. You can give them clonidine. There's a bunch of other things that we can do to make sure that these patients have some kind of multimodal analgesia. Okay, and then another question is, why is it that IV barbiturates like methylhexator are always mixed with an analgesic? I understand that they don't technically block pain, but I don't get why it matters if they are unconscious. Very, very good questions. So as we talked earlier, you want to make sure the patient is unconscious. So like you can give someone propofol, they're unconscious, right? But the minute they cut their skin, your sympathetic system is still conscious in a way, even though you're asleep. So your sympathetic system is just going to be like, oh my gosh, there's something attacking me, is what your brain thinks. Your fight or flight response is activated. So you have to blunt that with something. And usually the things that blunt it is an analgesic drug. So if, like an opiate like fentanyl, morphine, Dilaudid, you can give dexmedetomidine, you can give ketamine. So you need something else to kind of lower your sympathetic system, because otherwise, if you have our patient who's, I don't know how old that patient was, who was CAD and has known heart problems and their heart rate goes up to 120 for, 20, 30 minutes, you're stressing the heart on a heart that's really not functioning well. So they can have another heart attack under anesthesia. So this is why we make sure the sympathetic system is not completely turned on. Do you change the anesthesia care plan depending on how invasive the surgery is? That is, do you need less anesthesia during laparoscopic surgery versus open surgery? Very good question. I love these questions. These are great. we don't need per se less anesthesia, because by anesthesia, you guys have to be a little bit more precise, because do you mean most of the less of the sedative medication? Do you mean less of the analgesic medication? Those will be different, right? If your incision is a small little hole, then you won't need as much analgesia. So I'm not going to give you a bunch of fentanyl, right? But if you're having an XLAP where your incision is from the entire abdomen is open, you're definitely going to have a lot of pain afterwards, right? And so we give you a little bit more of the analgesic drug. So it's different depending on what kind of procedure is being done. What does intubation look like for patients who are having surgery on their mouth or face, maxillofacial? Yeah, the intubation, usually for these procedures, we do nasopharyngeal intubation. So we go through the nose. I'll briefly talk about, fiber optic intubation too. So that's coming up. I love these questions, keep them coming. And so once you're optimized, I'm going to run out of time because I have a lot more slides, but I'm going to try to go through these as fast as I can. So once you're ready for induction, you want to make sure all your things for induction are ready. So you want to make sure your access is ready. So they have an IV. So you don't want to bring a patient, they have no IV and there's no working IV, right? It can be very dangerous if you think you have an IV, you give a drug, you halfway give a drug and your IV is blown or infiltrated, right? And the patient is half asleep. You don't have anything else to give them, any kind of other medication. So it can become an emergency. So having an intact IV that's working is very important. Airway wise, you have to decide, do I intubate? Do I use an LMA? Is this going to be a difficult intubation? Do I use a fiber optic intubation? Do I use a video laryngoscopy? So you decide that based on your airway exam, right? Based on the patient's history. Our patient was pretty straightforward. We don't have any issues with the airway exam. So we're going to just do our usual direct laryngoscopy where we go in with a blade and intubate the patient. Monitors, you decide if you do your traditional monitors where you assess blood pressure, heart rate, O2 sat, and then temp and CO2, or do you want to do an arterial line? Do you want to do a central venous pressure? So you decide that based on the type of procedures and how sick the patient is. And then you obviously need IV fluids to give your drugs. You need your suction. Suction is part of our checklist because if there's any kind of event where the patient is vomiting during surgery, you can suction that out and make sure they don't aspirate. So suction is very important. And then you need to have all your medications ready. So medication-wise, this is for induction for our patient. What are we going to use? You can use midazolam, so an anxiolytic. So some kind of anxiolytic is helpful. Some patients do well with fentanyl. So you can, instead of giving anxiolytic, you can just give fentanyl and it will kind of sedate them and calm them down. And then for sedative, you can give propofol. So we usually would give propofol. And the paralytic drug, you can give rocuronium succinylcholine. A patient who has a history of GERD or reflux that's not well controlled, you want to make sure you induce them and you intubate them right away because you don't want any kind of aspiration. And that's called rapid sequence intubation, okay? The rapid sequence intubation means intubate as fast as you can to prevent aspiration because this patient has active reflux or has some kind of processes in their body that can make them prone to aspirating, okay? And then again, for those who are just joining, aspiration means the food or the drink, your gastric content comes from your stomach to your esophagus and then goes into your lungs. And that can happen once during induction of anesthesia, right? You have a full stomach, right? Or you have a small bowel obstruction, you have reflux that's not well controlled, you go off to sleep, you're completely relaxed, and then suddenly all the stuff that you ate comes up and goes to your lung, okay? So that's something to avoid for sure, and that's why we make sure patients are NPO for a long time. That's why we make sure patients don't eat before surgery, is to avoid aspiration, okay? And so when you do a rapid sequence intubation, you basically give the sedative drug to make them unconscious, so propofol. You give them some of the fentanyl, if you have it, to give them some analgesia. You can give the fentanyl afterwards as well. And then you paralyze them right away. And you want to use a paralytic that's short acting. You don't want to use a paralytic that takes 10 minutes to kick in, right? Because your whole goal is to make sure the patient is intubated right away. So you use a paralytic like succinylcholine that has a very, very short half-life and very fast onset. So it goes in and within the next 30 seconds to a minute, you can intubate. It's fast acting. It relaxes the cord, you intubate, and once you're intubated, and then it just gets metabolized in a very short time too. Within 5 minutes, it's gone. out of your system. So you have to give them something else to paralyze them. We sometimes use cricoid pressure with RSI, so with rapid sequence intubation. You're doing everything fast to intubate them, and then we usually use cricoid pressure, where we apply pressure on the cricoid membrane here to prevent the gastric contact from coming up. So we call that cricoid. RSI was cricoid. Okay. And so this is a picture of just the kind of the things that we use. So the metal is the direct laryngoscopy. You go in, you intubate with that. This is the tube that we use. This tube actually has a gyroscope stylet. This is kind of a tricky thing. This stylet is usually used for video laryngoscopy. Our usual stylet has just the regular stylet, but this is just for you guys to see. And then our drugs are color coded. So usually yellow means a sedative drug. So ketamine is yellow, propofol is yellow, dexmedetomidine is not yellow. And sometimes it's different based on hospitals. So usually yellow means sedation, sedative drug. And then red means paralytic. So usually red is paralytic. So the red here, succinylcholine, paralytic, rocuronium, paralytic, lidocaine is usually gray or any kind of local anesthetic. And then blue usually means opiate. So dilaudid, fentanyl, sufentanil, all these other drugs are usually blue. So it helps to kind of color code things. This is an oral airway, and then we have a temperature probe here, and you have tape to tape the tube. This is our video laryngoscopy. So this is the gyroscope that we use. If you decide to do a video laryngoscopy, you go in with the blade, and then you will be able to see the picture on your gyroscope, and then our suction is here. And so now once your patient is going off to sleep and you're going to try to put the tube in, right? As you're putting the tube in, you see the cords, right? And your goal is to see the cords. Your goal is to see A. A is what you want to see. You see the epiglottis. So the epiglottis is this little floppy pink thing that's sitting on top of the cords. And then you really want to put the tube in between the cords. That's kind of your goal. What sits under the cords here, right here in the black area? It's not really shown. It's not open right now, but that's your esophagus. So you don't want to put the tube under here in the esophagus. You want to go above in the trachea. And so there are different grades. So you go in and you're trying to intubate. If you see A, that's your grade 1 view. Okay. It's a great view. And so when you're intubating with someone and your attending is asking you, hey, what do you see? You can say, I have a grade 1 view, and everyone knows what you're talking about. If you tell me I have a grade 3 view, I also know what you're talking about. That means you're only seeing the epiglottis. And so that can become concerning, right? Okay, you don't have a view of the cords. We need to intubate this guy, and we only have a grade 3 view, right? If you have a grade 4 view, it's even more worrisome. So this kind of tells you your airway, what your cord or your airway looks like as you're intubating. And so now let's say you have a grade 3 or 4 view. Let's say you have a grade 4 view and you're like, oh goodness, what do I do next, right? So the first thing you should do is you need to be able to ventilate the patient, or the woman. I keep on calling her a guy, but it's a woman. My patient is a woman. And so if you can't ventilate her, you put the mask on, you ventilate her, right? Even though our initial plan is to make sure she's intubated really fast and does not have any aspiration, you're at a situation now where you can't really intubate. So you have to kind of break your own rule and try to intubate the patient. And so if you put the mask on, you put an oral airway, you're bagging the patient, and you're able to get some oxygen to the patient. Great. So that gives you like reassurance that, if anything, you're able to ventilate the patient. And so now you start thinking, okay, what do I do now? So now you can do an asleep fiber optic, right? You can go with a fiber optic scope. This is the scope right here. And you just kind of guide, you put the tube on top of the scope. The scope goes in the tube, so you can slide the tube in. So you go in with the scope and you go and try to get a view of the cords, right? Once you have the view of the cords, you go past the cords into the trachea. And then once you're in the trachea, you slide the tube in and then take out the fiber optic and put your circuit on the tube and start ventilating the patient. Okay, that's one way of intubating. And then let's see. How common are grade 3 and 4 views? I mean, it's hard to tell how common they are. They are not uncommon, let me say that. We do have patients who are grade 3 and 4 views. We do a lot of fiber optic intubations. Sometimes if we feel like a patient is a difficult airway, we will keep them awake entirely for the intubation. So it's not very pleasant. Patients don't like it, we don't like it, but it's the safest thing to do. So what we do is we numb up the airway. So we completely localize the cords, we localize the back of the tonsils, make sure, we ablate the gag reflex. And then once everything is numb, we numb them up pretty much with spraying with the lidocaine. We can do blocks, we can do a transtracheal block and numb up the entire trachea. We give them a little bit of sedative medication because you really don't want to lose the airway, right? The downside is, you put someone, you give someone some medication, they fall asleep and you can't ventilate them. You can't breathe for them, they can't get oxygen. It becomes an emergency, they can die. They can die if they can't get oxygen to their brain. And so you really want to avoid that by making sure you're able to intubate them. And if it's a patient who have a known history of difficult intubation, a patient who has oral cancer or nasopharyngeal cancer, a patient who has severe strictures and immobile, the neck is completely immobile. There are ways, we decide who to do an awake intubation on. And so if you think an awake intubation is the right thing and the safest thing to do for the patient, we do it. And so, for those patients, we completely numb them up and we go in with the fiber, go into the airway, put the tube in, and then we put them, they go to sleep. So, we do that, I would say, not uncommonly. So I've done, I think, 2 or 3 awake intubations in the last 6 months. So, we do it pretty consistently. What do you do during really long surgeries besides checking patient vitals? Very good question. We do a lot of things during long surgeries. It really depends what kind of surgery it is, right? Some surgeries, there might not be a lot to do if the patient is healthy, if the surgery is not very hemodynamically challenging, then, there might not be a lot to do. You make sure the patient is paralyzed, you make sure the patient is still asleep, you make sure their vitals are stable, you treat their blood pressure, you treat their heart rate. So these are the usual things that we do. If the patient is having a surgery that's very like a major surgery that will cause shifts of fluid, that will cause blood loss and things like that, we're very busy. It can become a very long day and very tiring day. When on our feet, we're checking vitals all the time. We're giving blood if needed. We check ABGs all the time in the OR. We're monitoring urine output. So we're communicating with the surgeon if there's blood loss. And so it can be, we're giving drugs, we're starting pressors on patients. It's basically running our own little ICU in the OR. So we're busy handling an ICU patient who's really sick and having surgery in the OR. So it can be very challenging. Okay. The more I'm going through this, the more I'm realizing I'm not going to be done with this whole thing. So this will be only probably half the presentation, but I'll continue until our time is up. So, and then once you induce the patient, then you do what we call maintenance, right? We talked about maintenance. And so maintenance, usually we use an inhaled anesthetic. For this patient, we're using sevoflurane, which is one of the inhaled anesthetics that's commonly used. And we make sure they're at 1 MAC. So 1 MAC is the minimum concentration of an inhaled anesthetic at 1 atmospheric pressure that prevents skeletal movement in response to surgical incision in 50% of patients. So you want every patient to be at least 1 MAC, right? Some patient might need more. If you're young and healthy and strong, you probably would need more of the anesthetic medication because your sympathetic system is a lot more. So you might need more to make sure all those reflexes are lower, versus an 80-year-old patient who doesn't have as much of a sympathetic output might not need a whole MAC. They might need 0.6, 0.7. And so on top of that, we also supplement them with fentanyl and opiates and analgesic drugs and other things that would not maybe require them to be at 1 MAC. Okay, so scenario number 1. So you're 20 minutes into the case. You know what? Let's actually, since I don't have the time, let me go through another scenario because I think the airway stuff is what's really interesting, you guys. So let's do scenario number 2. Okay, so we're running out of time. Let's do scenario number 2. So you're 20 minutes into the case and the patient saturation drops to 80% from 100%. What's your next step, right? And then this is the picture of your capnograph. So this is the amount of CO2 or carbon dioxide that you're exhaling. So your end tidal CO2. And usually there's a pattern of what your CO2 should look like. And this is what you see on your monitor. So what do you think is happening? So in 20 minutes, saturation is dropping. What do you do, right? This is why anesthesia can be really interesting sometimes. Things happen very fast. It's not like other fields where you have time to think about a disease process. You don't go in your office and open UpToDate or open a paper and really think about what you should do next. This is 1 minute or less. You have to really think on your feet. So anesthesia is like that, it can be chill and easy, but the next minute, if you don't think on your feet and do something about a situation, the patient can die. And so when this happens, you really have to be on your feet and really going through differentials in your brain, right? So when I see this for me right away, I know what's going on. The first one, it can be many things, but I kind of have an idea of what's going on. Just the fact that the saturation is dropping this fast, and this is the capnography picture that I see, I already know that this patient is having an issue of some sort. But really, you should have a systematic approach to these situations, right? When you have hypoxia, you have to think of yourself, is it the machine, right? I'm having a machine problem. We have a ventilator. Are we delivering the correct amount of oxygen? Is there a loose connection somewhere? Because we have a tube that's connected. So sometimes you can have a loose connection somewhere. Is the patient not getting enough oxygen? What's going on? Then you go to your endotracheal tube. So your patient is intubated. You have to make sure is the tube where it's supposed to be. Did the tube move? We move patients all the time during surgery, right? We position them for certain surgery. If you're having spine surgery, you're having surgery on your back, right? You're going to be face down like this on a table. So you come in the room like this, we intubate you, and then we flip you, boom, we flip you down like this. And so when you were flipping, there are times where the tube can be dislodged, right? So you have to make sure is the tube in the right place, it hasn't migrated. For this patient, the patient is going to be supine with their arms out like this during surgery. So there shouldn't really be any reason why the tube has migrated unless it's not taped well, right? Then you have to think of yourself like, is the tube too deep? Is the tube not supposed to be where it's supposed to be? So is it above the carina? Is it below the carina? Is it in the right main stem of the bronchus? Is the tube kinked? And then you start thinking about problems, right? Patient problems. Like, is the patient coughing? Is the patient having bronchospasm? Because the patient has a history of COPD? What's going on? So you quickly have to go through all of this in less than a minute and decide to do something about this. And so you look at the first thing you should do when the patient is desaturating that fast is to take them off the ventilator and then manually bag them and start kind of understanding of why they're desaturating so fast. Are they de-recruited? Sometimes when we inflate the belly, like during a laparoscopic procedure, the patient can have atelectasis. So their little alveoli can collapse and they need to be re-recruited, right? So you take the bag in your hand, you mask them, and you see if there's any difference in that. As you're doing that, you notice that the bag is really tight, super tight, like rock solid tight. And the sats have not really increased, 82%. And you look at your ventilator, your peak pressures are extremely high. So you start that with the desaturation and your end-tidal CO2 should really lead you to a diagnosis of bronchospasm, right? And this is a normal end-tidal CO2. So this should kind of looks like a square upside down or a rectangle upside down, but this is the patient is looking like these slanted, what do you call it? Like the slanted upslopes of the end-tidal CO2. And so this is kind of showing you every time the patient is expiring. So this is the expiration phase, right? The patient is expiring, right? And every time they're expiring, their bronchioles are so tight that air is barely getting out. So you have that really slanted, like the patient's struggling to expire, right? And so that kind of tells them they're having bronchospasm, so you start treating it. So you can treat with albuterol, you can give them albuterol to the ET tube and see if that helps. If that doesn't help, you can give them some ketamine. Ketamine is a bronchodilator. You can give them that, but also ketamine is a sedative drug, so they'll be more sedated when they wake up. And then if all things fail, you can give them some epinephrine, which will for sure bronchodilate. So, these are some of the things that we have to think about when we're dealing with anesthesia. And then scenario two is the surgery has ended and the patient is ready for extubation. So what are extubation criteria in the OR? So these are some things that we need to know. Is the patient has to be awake, they have to follow commands, they have to have some kind of normal, regular respiration and tidal volumes, their vitals should be stable, they should be able to have good strength. So usually we say sustained head lifts, so able to kind of lift their head, have some purposeful kind of movements as well. And so quick example here is like, should I extubate or not? So this is on the left side is a patient who's on pressure support, which means you're supporting their breathing with the machine. So you're giving them a support. This patient has support is 15 and this patient is 5. So this patient has less support and doing well. This patient is requiring a lot of support to breathe. And even with that, their tidal volume they're pulling is only 150 versus 450 was a less support. Already you know that this patient is doing better. And then this patient, the respiratory rate is only 5. So they're not really breathing as much as they should, versus this patient is breathing about 12 minutes, 12 times a minute. And then you also look at their end-tidal CO2, and their end-tidal CO2 is super low, right? Versus like a normal end-tidal CO2. So these are all things, and saturation is not high enough, and this is a pretty better saturation. So just looking at this, you kind of have an idea, okay, this patient is not ready to be extubated. And you start thinking about, okay, why are they not ready to be extubated? Is it because we gave them too much opiate drugs? Is it because they're too sedated? Is it because they're still paralyzed and they're not completely unparalyzed, you know? So you have to think about all these things as you're thinking about extubating a patient. Okay. And then you're like, okay, well, your patient looked fine, you extubated them, everything looks fine, and then suddenly you're like, their saturation drops to 70% and you're unable to ventilate. So it's, you know, you extubated, everyone's getting excited to leave the room, and then suddenly you hear the pulse ox going, that means the saturation of the patient is dropping. So immediately you turn around and the first thing you do is ventilate the patient. So you put a mask on their face, you hand back them to give them oxygen and support them. And then you realize you're not able to ventilate. You can't even get any air, any kind of oxygen into their lungs. So what do? And what's your diagnosis, right? The first thing you should think about is patients when they get extubated can laryngospasm. So depending on when you extubate them and how deep they are, how light they are during extubation, their cords can close. So after you extubate them, they seem like they're fine, and then suddenly their cords spasms, and then they close. When they close, you can't get any air into them or any oxygen. And so they start deciding, and they can code, right? They can die for not getting enough oxygen. So this usually happens. You guys remember stage 1, 2, 3, and 4 of anesthesia? This happens if you extubate them during stage 2. So when they're kind of waking up, they're coughing, they're moving, everyone thinks, oh, they're ready to be extubated. Let's extubate, right? Everyone's like, all right, let's get out of the room. Let's extubate. No, right? This is stage 2. If you extubate them during stage 2, they can have laryngospasm and cause a lot of issues for the patient. And so you just have to wait it out, right? Their breathing has to be better. They need to be more coherent and able to follow commands, right? They need to, usually before they're about to extubate, if you tell them, hey, take a big deep breath, they're able to take a big deep breath. They understand, they follow commands. They might not remember, but they're able to follow commands. And so that happens when you extubate them at stage 2. So for laryngospasm, what you do is you try to open the cords, right? One way of doing that is to put your hand on the patient with the mask, and then you close your APL and give them a lot of pressure, or CPAP, just continuous pressure, and then you hold the bag to be basically applying pressure. You're putting so much pressure on the cords that they just open. That's kind of what you want. You want a lot of pressure on the cords, and you're gonna force them to open, right? And so you do CPAP. Usually that's kind of the first thing you do. If you can't really get with CPAP, it takes like, you do CPAP for maybe 10 seconds or so, nothing is happening. The next thing you need to do, you just need to artificially relax the cords, right? One way of doing that is giving them sedative medication and relaxing them. So you give them propofol, you deepen their anesthetic. With propofol, usually they kind of relax, the spasm stops, and the cords open. Sometimes with just propofol, it doesn't happen. So at that point, after giving propofol, if you're still in laryngospasm, then you give them some muscle relaxant. So succinylcholine is, again, we talked about it earlier. It's a quick offset drug. So you give them succinylcholine, the cords relax, you can ventilate them. Obviously, because you gave them a bunch of propofol, they're going to be asleep. So you can stand there ventilating them until they wake up and start breathing on their own. Okay, so. And all right, I'm almost out of time. So you know what? I'm going to skip all these things and talk to you guys a little bit about pain control. So in Post-op, we do one of our jobs to make sure patients are not in extreme pain or somewhat comfortable after anesthesia or surgery. And so, we give them IV pain medications, opiates, we talked about ketamine. We even can do lidocaine infusions. Sometimes, depending on the surgery, if they have a big abdominal wound, we can do an epidural. So we can place the epidural and give them analgesia that way. And then we can do also nerve blocks. So for those who are interested, for this patient, let's say this patient had a big incision. If he wasn't laparoscopic and they had a big incision in their abdomen, we can take an ultrasound, scan the abdomen, and find the nerves that travel between the muscle layers and block those, okay? And so one of the blocks that we do is called tap block, okay? So this is, the anesthesiologist using the ultrasound, and as they're using the ultrasound here, you can see the layers. So these are the different layers if the tap block. So EOM is the external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle. So you take your ultrasound, you anesthetize the skin, you take your needle, the white is the needle, you go in and you deposit a bunch of local anesthetic in this area and numb up the nerves. And the patients are comfortable after that. So that's one of the things that we also do, is nerve blocks. Let's not talk about this. Okay. Now, since I'm running out of time, I do want to talk about global health and equity. So I'm very much interested in that. And, globally, there's a huge lack of skilled anesthesia providers. And so that becomes a huge barrier to safe and affordable surgery. And so, patients who need surgery can get safe surgery, or if they do, they end up having serious complications afterwards. And this picture is from the World Federation Society of Anesthesia. It kind of shows you that certain areas are affected disproportionately to other areas, and there is a huge disparity. And so in sub-Saharan Africa, it's all red, and that kind of shows you how scarce anesthesia providers are there. And this is the legend here is physician anesthesia providers per 100,000 people, and there's less than 0 to less than 1 is the red part. And high income countries like USA, some parts of Europe, you can see they have at least 20 plus. So there's a huge disparity. And this is one of the studies that was done by the WFSA, and it kind of shows you again the same thing, that in low income countries, LIC is low income countries, the amount of anesthesia providers per 100,000 people is 0.2, and high income countries is 18. I mean, this is huge, right? This is just a huge disparity. And one of the things that I like doing is kind of working in a global setting as well. And one of the things I did last year is do the Safer Anesthesia from Education course, where we go and educate anesthesia providers in different countries on how to safely give anesthesia. This was in Tanzania, where we had an intense, 3-day course of different types of providers who came in and got training on the core principles of anesthesia for obstetrics patients. So we went through how to do a spinal, what to look for during a spinal, how to, safely place an epidural, what the big emergencies are during for obstetric patients, what some of the comorbidities are, patients who have preeclampsia and eclampsia. And so this was a kind of a refresher course for these providers. And then another thing too is, medicine is not very diverse. And this is a graph from this is on the left side, it's from the AMCA. It shows the percentage of applicants to US medical schools by race, ethnicity in the year of 2018, 2019. And it shows you the different applicants by race and ethnicity in different colors. And so you have white is in orange, Hispanic is in green, and then Black is in blue, and what is it? What's this one? This is 9.2% is multiple races and ethnicity. And it kind of shows you that some races are disproportionately magnified, I guess, in these med school applications. And this is compared to your general population, right? The general population does not reflect the medical school applicants, faculty, and people who work in healthcare in general. And so one of the things that I'm doing is a mentorship program for pre-medical students. So I'm on Instagram, we run it, and it's been going really well. It's called Mulu Mentor, and it's a virtual pre-medical mentorship. We match pre-med students who are underrepresented. So to apply, you have to be within 1 or 2 years of your medical school application. You have to be underrepresented or disadvantaged on your application, and we match the students with the physicians who are from the same background. So to give them, advice, review their application, give them MCAT studying tips. We review their personal statement. We do mock interviews with them. We network. And so it's been going really well. So this is one of the things that we're doing to make sure this gap in racial gap is kind of merged in a way. Okay. So that's it. I've skipped a lot of stuff. And what else? And this is, I was asked, what's an advice for a future physician? What I said is, don't allow anyone to define your potential. The only person you need to convince you're good enough is yourself. So thank you everyone for attending. This is my email address. I have an Instagram. So this is my I guess professional Instagram, and then the Mulu Mentor that we just talked about, the mentorship program. And I'll also just start a YouTube where I'm going to be starting to talk about anesthesia, different cases maybe, and talk about, being a pre-medical student and the things to consider in medical school and so on. And so feel free to follow me on there. So before I finish, let me just answer a few more questions. How do you stay composed during emergencies? Very good question. Anesthesia is a field that can have really wide swings. So you can just be doing a normal case, healthy patient, like a 25-year-old with no medical issues, coming in for a simple procedure, easy case, right? But they can get bradycardic and heart rate can drop to the 30s. And you need to be like, that can be scary. Or they can have a complication during surgery, or, where accidentally, a major artery gets cut and they have massive bleeding, And so it's a field for sure that will challenge you. And it's a field that you need to be able to think on your feet. It can get very stressful, I'm not gonna lie. And so you really have to have that personality. I think personalities who are very high strung and stressed out and very anxious might not do well with anesthesia. Usually it's the type of people who are able to be very versatile. So you have to be able to kind of think on your feet, but then also kind of relax sometimes. And so it's hard for everyone to deal with emergencies. The good thing is you ask for help. So if there is a major issue going on in the OR, there's a call button. So the nurse in the OR will call that button and help is going to come. So people who are free and not doing anything or not really doing cases will come to your room and help out. Because the main thing is, in any scenario, if a patient codes, right? If you have an event where a patient starts breathing in the ICU or on the floor, the first thing you do is call for help. So because there's other people coming in, and having a second look to the situation is always helpful. So it helps to have people nearby as well, able to help. Are all these drugs stored in the room for these situations? A lot of the drugs are stored at room temperature. There's some drugs that we definitely store in the fridge. Like for instance, insulin. Insulin has to be stored in the fridge, otherwise it doesn't work. And so that's one example. How come you need patients to be sedated to intubate, but need them awake to extubate? Oh, very good question. When when you extubate them, they still, a lot of them don't remember because they're still coming out of anesthesia. When we say awake, really depends. If a patient was a difficult intubation, and so you had a lot of trouble intubating them, right? They were an awake intubation, you did a fiber optic intubation. When you extubate them, you definitely don't want to have any issues extubating them, right? It's the same thing. If you have trouble taking off, you probably have trouble landing, right? Something is wrong with the engine. And so you just want to make sure that you have all your bases covered, and you don't want to have any kind of airway event when the patient's extubated. So for those patients, for sure, you need them to be completely awake before you pull the tube out. You want them to be responding awake. In the ICU, oftentimes patients are awake and have a tube in. They're awake, they say hi to you, they write to you, and they're not able to be extubated because they're not able to protect their airway. So it's not unusual to have patients completely awake for extubation. Obviously, there are a lot of times where we pull the tube out when the patient's completely sedated under anesthesia, but breathing on their own. But that's a decision that needs to be made case by case. What do you work on when you aren't in the OR? Are there downtimes during the day? When I'm supervising CRNAs, I'm not in the OR. So I'm out of the OR, and my job is really to make sure things are going as planned. So I make sure the patients are doing well. I check on their vitals. I touch base with the CRNAs. I put orders in for pre-op and post-op. If there are any issue in PACU, I go address those issues, So you're never really like just sitting around. There's definitely some times where it's kind of down, if you're doing OB anesthesia, there's no laboring patients, then you do your own thing, right? You have projects to work on, you can do that. Do you have any suggestions for how pre-meds can support initiatives of global health and equity? I would say when I was a pre-med, what did I do? When I was a pre-med, I had the interest in global health, but I never really did anything about it, and I wish I did. I think as a pre-med, it's finding out people that you're interested in, who you would like, people who have the career path that you are interested in, and contacting them and asking them, hey, are there any opportunities where I can participate, or can I be part of your project? So is there any projects you're working on, and so on. So I think connection is really important initially. Once you're in medical school, I think choosing a medical school that has global health is important. So if you want to do global health as a career and you're really interested, when you interview during medical school, you can ask them what kind of global health initiatives they have. So in medical school, my fourth year, I went to Tanzania as a rotation. I did an anesthesia rotation, and it was awesome. I loved it. I learned so much. And I felt like that's something I want to do on a regular, So that was what kind of led me to continue doing global health. And then in residency, I did the same thing. I went to Ethiopia and I worked with a bunch of amazing folks in anesthesia. And so I felt like that was another reconfirmation that that's something I want to do. So you have to start doing this early on. And it's not easy. There's no good recipe, You just have to start asking and emailing people and asking if there's any way you can help and so on.
Thank you so much, Dr. Beti, for taking the time to answer our questions and for such a wonderful presentation. Everyone learned so much. Thank you so much once again for doing this.
Of course, it was my pleasure. And thank you so much for listening. Send me an email, and if you have any questions about mentorship and stuff, you know how to contact me. It was a pleasure. Thank you for listening.
No problem. And everyone still watching, make sure you check out Dr. Beti on her socials. She's also tagged in our Instagram. And the Google form has been posted in the chat and in the description of this video, and you have 30 minutes from now to fill that out.